Welcome to Medic Empire. To truly understand cerebral palsy, CP, you must first grasp its core definition. It is an umbrella term for a disorder of movement and posture that limits activity stemming from an insult to the developing brain before its complete maturation. The cardinal rule to remember is that the underlying neurological lesion is non-progressive. However, the story doesn't end there. While the brain pathology itself is static, the child's clinical manifestation is dynamic, constantly changing over time as the impaired lesion interacts with a growing, maturing nervous system. The origins of this insult can be traced across three distinct chapters of a child's early life: prenatal, intrapretum, and postnatal. Prenatally, the developing brain may be assaulted by genetic abnormalities, torch infections, chorioamnionitis, or placental insufficiency. During the intrapretum phase, birth asphyxia is a classic culprit. Postnatally, the brain remains highly vulnerable to prematurity, bilirubin encephalopathy kernicterus, meningitis encephalitis, intracranial hemorrhage, and hypoglycemia. When this child arrives in your clinic, motor impairment will be at the absolute core of their presentation. A sharp medical student will look for early clues in the history and physical exam: delayed motor milestones, feeding problems, undue lethargy or irritability, toe walking, and speech delay. A major red flag is early hand preference before 18 months of age. On examination, you might note hypotonia or hypertonia with sustained clonus and increased reflexes, poor head and trunk control, and the persistence of abnormal primitive posturing like gum adduction, fisting, or leg scissoring beyond 6 months of age. As the child's nervous system mature, the specific motor phenotype of their CP will emerge. You must be able to classify this tone. Spastic CP, characterized by a velocity-dependent increase in tonic stretch receptors. When you dynamically assess this spasticity, it will often feel like a clasp knife resistance. Dystonic CP, this presents as sustained muscle contractions leading to abnormal posturing, often feeling like lead pipe rigidity. Over time, this unrelenting spasm can lead to severe contractures. Choroathetoid CP, you will observe hypokinesia characterized by excess involuntary writhing movements. Ataxic CP, here the primary deficits are uncoordinated movements tied to a disturbed sense of balance and depth perception. These tone abnormalities settle into distinct anatomical patterns that often hint at their etiology. Spastic diplegia, where lower limbs are affected more severely than upper limbs, is classically seen in premature infants. Spastic quadriplegia affects all four limbs, upper more than lower, and is often linked to term infants who suffered birth asphyxia, frequently presenting with decreased cognition. Hemiplegia, one side upper limb greater than lower limb, usually points to a middle cerebral artery MCA infarction. Meanwhile, dyskinetic athetoid CP is typical of term infants who suffered bilirubin encephalopathy, notably with preserved cognition, and ataxic CP relates to cerebellar hypoplasia or genetic causes in term infants. Because a mixed picture of movements is common, simply naming the subtype doesn't accurately describe the child's function.